Welcome to ACOG's 2015 Annual Clinical and Scientific Meeting. It will be in San Francisco, and I'm sure I'll see you there. If you're just joining us, we're trying a new technique called Flipped Classroom. Not only is it new to you, it is also new to me, so bear with me and let's see how this plays out. I'm going to give a series of 3 10-minute videos on the most common topics in female sexual dysfunction. When it comes to the actual classroom in San Francisco, I hope that you will have reviewed these and then will bring your cases to me so that we can discuss them and share the treatments and ideas amongst all the participants. So this is video number 2, and we're going to talk about sexual pain. Video 1 talked about desire, and sometimes pain does influence desire. So you have to be very specific as you run down the history on these patients to figure out what's the real problem. So when it comes to painful sex, in my mind I divvy it up into different age groups as well as different etiologies. So let's start with the easiest one, I think, to me, and that is painful sex due to vulvovaginal atrophy. In most cases, the atrophic woman is also the menopausal woman, and as you know, this is a chronic progressive problem throughout the lifetime. So don't not ask the lady who's 82 whether she's bothered by her vaginal atrophy, because sometimes no one asks, and it is extremely important throughout the lifetime. So pain in the menopause happens to be the cause of no sex for half of my patients. 50% of patients who aren't having sex in the menopause are not having sex because it hurts. How easy is this for us to fix? Simply by asking the question. So you know the pathophysiology is estrogen deficiency, the tissue gets thin and pale and non-elastic. You're very familiar with the treatments available. There are creams, estrogen creams that you can use. My preference would be a quarter of an applicator, not placed in the vagina, but measured in the applicator, and then applied to the fingers and to the vulva, introitus, wherever the patient wants it, even in the perianal area, twice a week. Sometimes the oncologist will give us pushback on this in perhaps a breast cancer patient, but you can simply do a pre-estradiol level on the patient, serum estradiol, and then 6 weeks into therapy, repeat that estradiol level on patients using estradiol cream, and you will find that the estradiol level does not increase when using a quarter of an applicator twice a week. If you prefer a non-estrogen management for this problem, there is now an oral non-estrogen treatment that is FDA approved for the female for dyspareunia and due to atrophy. So this is a daily medication that has to be taken with food, and this may be an option for your patients. There are also some tablets that go in the vagina as well as a ring, and each of them are effective in correcting this problem. What the patients don't understand is that it has to be taken forever, or simply as long as they want to take care of the problem. However, I will tell you there is data out there that says if you have 2 penetrations a week, you will maintain the youthfulness of your vagina for a lifetime. In fact, I have seen this. I have seen 82-year-old women with a vulva and vagina that look like they're 40 because they've maintained regular sexual intercourse throughout the decades. So to me, that's the easiest one. Don't forget that vaginal atrophy can also occur in girls on long-term birth control pills. Long-term birth control pills really suppress her natural estradiol and can allow a thinning of the tissue. So be alert for this. I would not use the pill that's non-estrogen, the SERM, for those women, but I could use the vaginal creams. Okay, other things to consider with vaginal pain. Is it pain on insertion or pain on deep penetration? Some women have that very confused and they say both, so I really ask those questions in detail. Pain on insertion can be infection, lichen sclerosis, irritation, contact dermatitis because they're using liquid soaps or baby wipes and things like that. So look at the introitus, look at the skin, get a closer look. Probably the most commonly missed thing that I see is vulvar vestibulitis. Vulvar vestibulitis is inflammation in the minor vestibular glands. So if you actually did a vulvoscopy, which is using your colposcope to look at the vulva, not only is that a reimbursable code, but also you're getting a nice view of the tissue, and you can find little pockets of redness that may clue you in. But simply a Q-tip test in your office can be effective, and the patients can tell you where it hurts and where it doesn't. Treatment with potent topical steroids as well as a little estrogen cream combo are very effective here. Sometimes I use testosterone off-label in a testosterone gel or cream to the vulva, as there are androgen receptors in the vulva as well. Pain with deep penetration, as you are all very familiar with, can have to do with a pelvic pathology, endometriosis, fibroids, and so forth. So make sure you evaluate that as well. When we're talking about any kind of pain with sex, it is the one complaint that most men will do a complete hands-off. So I will also report to you that probably 20% of my patients who claim pelvic pain, I don't think really have pelvic pain. I think they use it as a tool to keep their husband from approaching them for intercourse. So that goes into the psychology side of what the heck is going on in that relationship to make her say that it's painful. Vaginismus is a condition where there's a spasm where you can't enter a finger, a tampon, or anything into the vagina. I get a lot of referrals for vaginismus that aren't vaginismus. They're generally situational vaginismus. The penis is too big for the small vagina, or at least in her mind it is. His approach is too rough. But for the most part, vaginismus is an anxiety condition. And so lots of hand-holding and a good sex therapist can really help the patient with vaginismus. If you don't address it, this can impair relationships for a lifetime. Think about lubricants in your patients. Intercourse is friction. So lubricants are just as important as estrogens when we talk about the vulva and vagina. There are water-based lubricants such as Astroglide, which happens to be one of the few that you can get in your mouth. It has sort of a sweet taste to it. And water-based lubricants are safe for everyone and readily available. Silicone-based lubricants are fantastic for the ultra-dry vulva of the menopausal lady. Silicone lubes only require a drop or two and stay on the skin very nicely for long periods of time. Be very careful that you don't spill this lube on the tile, because if somebody steps in that, someone will break a hip. And this is a whole ER visit that you just don't want to get into. So silicone lubes are very slippery on the floor or the tile. They do stain the sheets a little bit harder to get out, but a very nice tool for staying on the skin as they don't absorb as quickly. Great for the aging menopausal women and readily available in stores and on the internet. There are moisturizers for the vagina that generally are placed in the vagina and last for 3 days. And there's a variety of beads or applicators full of gel that just are prolonged moisturizers. And all of these can be used in combination. We also want to consider pelvic floor therapy as an alternative for patients with chronic pain. So don't forget the importance of pelvic floor physical therapy. These days you can actually offer this in your own office and monitor these patients directly. So keep in mind, when you think about pelvic pain, A, it's extremely important. B, what is the etiology? 3, what remedies am I going to offer, or many? And address these problems right away and don't overlook them, because after all, it is important to have a lifetime of great sex.